IBD and colon cancer. Why is screening different? Imagine living with a condition that not only affects your daily life but also changes how doctors keep an eye on your health. That's what happens with people who have inflammatory bowel disease, or IBD. Because of the way IBD causes ongoing inflammation in the colon, the risk of developing colon cancer is higher and more complex compared to the general population. This means screening for colon cancer in IBD patients isn't just a routine checkup. It's a carefully tailored process designed to catch problems early when they are most treatable. In people with IBD, especially those with long-standing ulcerative colitis or Crohn's disease affecting large parts of the colon, the risk of cancer increases over time. Chronic inflammation can lead to changes in the cells lining the colon, called dysplasia, which can develop into cancer if not detected and managed early. Unlike typical colon cancer, which often starts from a visible polyp, cancer in IBD often begins from flat or subtle lesions that are harder to see with standard screening methods. Because of these differences, doctors start screening much earlier than for people without IBD. Instead of waiting until age 45, surveillance colonoscopy usually begins about 8 to 10 years after the diagnosis of IBD. The reason is that the risk of cancer begins to rise after several years of ongoing inflammation. The screening is also more frequent, often every 1 to 2 years, depending on individual risk factors such as how much of the colon is affected, how severe the inflammation is, family history of colon cancer, or the presence of other conditions like primary sclerosing cholangitis, which further increases the risk. When it comes to the actual procedure, advanced techniques are used. High-definition colonoscopy combined with chromoendoscopy, which involves applying special dyes or virtual imaging methods, helps doctors better identify suspicious areas. This is different from the general population, where simpler colonoscopy or stool tests are often enough. In IBD, targeted biopsies of suspicious areas are preferred over random sampling because dysplasia tends to be visible or located in specific spots, making detection more accurate. If dysplastic lesions are found, the goal is to remove them endoscopically if possible. Surgery is considered only if the dysplasia is high-grade, multifocal, or if the lesions cannot be completely removed. The entire screening process is personalized, taking into account factors like how much inflammation there has been over the years, previous dysplasia, strictures, or family history. This tailored approach helps ensure that each patient gets the most appropriate surveillance schedule. In contrast, people without IBD usually begin colon cancer screening at age 45, with options like stool tests or colonoscopy every 10 years. Their risk is lower, and the cancer usually develops differently, often from polyps that grow over time. To sum up, screening for colon cancer in IBD patients is different because their risk is higher and more complicated. The goal is to catch any early signs of cancer or precancerous changes as soon as possible, using more sensitive detection methods and personalized schedules. This approach is supported by current medical guidelines and aims to reduce the chances of colon cancer developing or progressing unnoticed. If you or someone you know has IBD, it's essential to work closely with healthcare professionals to develop a screening plan tailored to individual needs, helping to protect colon health and catch problems early.